And so another lived experience is being a female in the health professions and what this means. So Kim, what are some systems-based interventions that could be explored to address the risk of burnout among female students, be they physicians, nurses, physical therapists, whomever? And at what point during the career should interventions be initiated?
And as I'll be talking about here briefly, we need to be starting the interventions early. You can see issues with burnout and especially gender-based differences in burnout, even among medical students. You certainly see it among residents. And so I think we need to be starting with medical students and potentially even with pre-medical students so that they know what they're getting into for a career and we can start working on their coping strategies. And I'll be talking about some of the other interventions that we can potentially do when we get to talk about some of the issues of burnout among female physicians. And so when you look at gender differences in burnout, unfortunately not all studies of burnout provide the results based on gender. For the studies that we have, it looks as though exhaustion, especially emotional exhaustion, tends to be higher among women. Depersonalization tends to be higher among men. But are there really gender differences in burnout? Is it more socially acceptable for women to complain of some of the symptoms of burnout? If they're more likely to exhibit emotional exhaustion, is that easier for themselves and others to pick up? Or are there actually differences in incidence? And I'll be talking about potentially some causes for that if that does exist, but we need more research to see exactly where this lies. There are several studies out there, though, that look and identify gender-based differences. This is looking at internal medicine residents and show that women are much more likely than men to meet criteria for burnout. Again, is that they're more likely to admit that they have symptoms of burnout, or are they truly more burned out? And again, indicating that women are more likely to demonstrate exhaustion. We do an annual survey, as I think almost every GME program does, of their residents to see what their wellness is. In the survey, we found that women were more likely than men to be burned out at our institution, not significantly so, but there was a higher risk, especially among second-year residents. And so I approached Dr. Jeff Norville, who is the chair of our GME Wellness Committee, to see if we could look at this, and he put together some focus groups of third-year female residents to talk about burnout and some of the factors that they thought contributed to their burnout. So I'll be providing some of the responses from those focus groups. My areas of interest are on the opposite ends of the spectrum of physicians' careers. I'm interested in the issues of female residents, but I'm also interested in the issues of senior female physicians, those who are nearing the end of their career and getting ready for retirement. When you look at the literature, there is nothing out there. The only thing that's out there for senior physicians, and that's both male and female, was a study from Great Britain that came out last year that talked about health conditions, but nothing that talks about emotional health, nothing that talks about burnout. And so when working with Dr. Ann Walling, also from our institution, we applied for and received the Giambalvo grant from the AMA, so we're grateful for receiving that to actually study the issues of senior female physicians. We have finished a series of focus groups to talk about the issues, and that now has been translated into an electronic survey that has been sent out. So I'll be reviewing some of the issues that we think that leads to burnout among female physicians, but then providing some of the comments from the focus groups about the residents and the senior physicians that tend to reflect what's in the literature. So some of the issues that may make women more likely than men to be burned out is that we have differences in communication styles and interpersonal interactions. We're more likely to suffer from imposter syndrome or stereotype perception threat. Gendered expectations, both from our coworkers and our families, but society in general. Gendered expectations of ourselves, because we get those as we're reared in this society, and potentially the impact of sexual harassment and conscious or unconscious bias. And I'd like to thank Dr. Carol Bernstein for this slide that we used at a recent presentation, but one of the issues in communication styles is that women tend to have more of the mother transference. We tend to be the problem solvers, the peacemakers, we're nurturing, we're self-abnegating. But does this interfere with our ability to work with patients, and does this impact our own health? Does it mean that we're spending more time with patients, we're expending more emotional energy? On the other hand, does it mean that we're less likely and have more difficulty in delegating family responsibilities? In a study that came out earlier this year, the comment was made that the motherly approach to patient care may be best for the patient, but it can be draining to female physicians, and this study specifically focused on surgeons. There also is the increased risk of compassion fatigue. This, again, is a study of surgeons. And this is a study that was distributed through the American College of Surgeons and found that female surgeons from all specialties showed significantly higher levels of burnout and compassion fatigue compared to male surgeons. So again, is this an issue where we tend to spend more time with patients and tend to be more emotionally involved? We also have to deal with the issue of imposter syndrome, which, as you know, is more common among women than in men. This is an issue of people feeling that they're going to be found out as intellectual frauds. Even though they've been given excellent evaluations, they have great test scores, we still don't think we know what we're doing. Is this a personality characteristic? Is this something that comes about as a result of training? This seems to be more of an issue as people undergo professional identity development. So as you're faced with new challenges during the course of your career, you start to wonder if you actually know what it is that you're doing. This may be good in that it may make some people more likely and more motivated to perform, but on the other hand, it's also been linked to distress, depression, and anxiety, so not necessarily a good thing. When you look at imposter syndrome, this was a study looking at family medicine residents. More women than men scored as imposters, which is not unusual. But it was concerning when you read some of the input from these residents, in that majority of the senior female physicians worried about their ability to practice. Even though they had received excellent training, they had excellent scores, they worried about their ability to practice, and these people were more likely to be depressed, anxious, and had lower self-esteem. And we wonder, is this something that's part of training, or do residents start training with imposter syndrome? And again, this is also found especially among fourth-year medical students. And there's also the issue that is somewhat related to imposter syndrome, which is a stereotype perception threat, in which we're concerned that we're going to do something that manifests or confirms stereotypes that we think that other people have of us. In this study, both male and female physicians thought that the public and faculty believed that men were better physicians. But the difference was that there was no psychological consequence to the men for having the stereotype perception threat. However, women who were concerned about doing something that supported the thought that that the faculty and public thought they were not as good physicians had worse psychological health, because they're constantly trying to prove that they can do what is anticipated of them, and that they don't want to prove that stereotype, that they're not as good a physician. They don't want to prove that stereotype. So looking at some of the comments that were made by our female third-year residents in their focus groups, they felt that they didn't know anything, but they yet were still responsible for patients. Well, they must have known something because they graduated to their third year in residency. They felt like they were expected to always look like they knew something even when they didn't. They felt that they were responsible for everything in the room, whether it was somebody's emotional status or how bright the lights were in the room. I was proud of the woman who brought up imposter syndrome. She'd actually heard of that and thought that was a major issue, and they thought that they had to be superwoman. Among the senior female physicians, they thought that women during their career had to be held to a higher standard by themselves and others. A big concern that no matter where they were in the wrong place. When they were at work, they should have been at home. When they were at home, they should have been at work, and there's still a lot of guilt that they had because of that. Looking at the potential impact of harassment and discrimination on burnout among women, there's not a lot of data in this other than showing that harassment and discrimination do occur, especially during residency. The majority of both female and male physicians are exposed to that at some point, more likely if you're female rather than male. Looking at gender-based discrimination, it comes from all sources in this study through the Association of Women Surgeons. The gender-based discrimination came from superiors, peers, support staff, and patients, so it was not isolated only to colleagues. The concern with being exposed to discrimination, as this is data outside of medicine, is that there are significant risks of being exposed to discrimination, in that one tends to withdraw and have both physical and emotional withdrawal and potentially leave the profession. So looking at the comments made during the focus group of our female residents, they thought that the staff assumed that the male, even if it's a male medical student, was more likely to be the senior resident than the woman in the room. They felt that they were often pointed out as the only female resident. They said this wasn't a negative, but they didn't understand why that made a difference. They also stated that they recognized that these comments were unconscious. However, one of them said it's the little things that really add up to create stress. In the gender bias discussion for senior female physicians, many of them talked about being bullied or harassed earlier in their careers, that eventually you just get over this, but you could tell from the conversation and the way this was framed that they were still upset about this because they could still detail specific events that happened earlier on in their careers. But we don't know if and how this impacts burnout. And then the big issue of work-life integration. This is a big issue for both women and men, but seems to be a more significant issue for women than men, in that women are more likely to have a negative impact on both the work-home and home-life integration. There tends to be more conflict, especially among women physicians, between work and home, and that can impact potentially their mental health and their risk of burnout. However, we were talking a lot, obviously, earlier today about loneliness and the need for significant interpersonal interactions. And this has been brought up in many studies. It's not just having someone there for support, but having support that's significant. And so in this study, they looked at 25 rural female family physicians, and they identified ways to develop an appropriate or positive work-life balance so that they could have positive interactions in one role that then positively impacted their other roles. And that was to have positive interactions and also to have a firm boundary between their work and their home. Parenthood, likewise, doesn't have a negative impact as long as there's support from the family, the spouse, or the significant other, as well as support at work. And so it's not necessarily having children or not, but as long as you're having support at home and at work and what you're doing, this seems to have a positive impact on women. And this is brought up repetitively by the senior female physicians. They thought that there was always tension between work and home, especially among the international medical graduates whose families were not in the U.S., so they couldn't help rely on them or have input from them in terms of childcare. But all of them thought that they had made some compromise in their career, an advancement in their career because of having a family and having children. There are a variety of different coping strategies, too, that one can deal with this. The coping strategies tend to be different between women and men. Women tend to reach outside for support, which is positive, but also tend to have self-blame, which is negative, which may be one of the main drivers to women developing burnout. And so what the senior physician said is that they wish they had not set this unattainable bar and then try to beat yourself up because you didn't meet it. So that fits into the self-blame issue that is seen in several studies. They said they shouldn't have been striving for perfection. But the constant theme that came up when I asked them what would they tell their younger self when they were entering their career, the consistent theme was take care of yourself. Take time for yourself. Take time to renew and refresh. Take time for your health, see your healthcare provider, and take time for exercise. So I think this is something that hopefully we can take back to the younger female physicians. And just briefly on the role of mentors, and we talked about what is something that we can do from an institutional standpoint, is provide advisors or mentors. These will help women understand how to navigate the political climate in the healthcare environment, help them hopefully work through the work-life and life-work interactions and potentially conflicts in both of those areas, and try to deal with some of the issues that lead to imposter syndrome, again, trying to navigate new waters during the course of their careers. And this is something, too, that was brought up by the female residents. They thought if there was one thing that could change would be if they would have an assigned mentor to help guide them through their careers. So thank you.